I'm Jason Chow, the Sheriff's Office, St. Genevieve County Sheriff's Office. We have a thing on our website for text casting where individuals can get weather alerts or community information either a text to their cell phone or by email address. And it's sometimes difficult to find it on our website, so I'm going to show you kind of direct you on how to do it. If you go to our main website and you go down to this area here where it says links and you click on it, it's going to bring up another page. And underneath that page, about the fifth one up from the bottom, it says sign up for text casting alerts. If you click on that, then it'll take you to this additional page. And here's where you'll sign up. You'll put your name, first name, last name, your time zone, and your zip code. And then if you want a text message, you'll click yes, or if you want an email, you click yes on that. And then you'll select if you want community alerts out of St. Francis County, St. Genevieve County, or weather alerts out of St. Francis County and St. Genevieve County. And then you'll hit continue. If you do the text, then it's going to send a code to your phone, a 5-digit code. You'll have to text that, take that 5-digit code, and you'll have to put that into the website here, and then hit continue, and it should accept everything, and you'll be good to go, and you'll be getting alerts then.
Come on, Lisa.
No.
She can get videotaped. Yes, I'm going to be giving her a tetanus shot that has the protection for whooping cough also. It's called Tdap. Whooping cough is an illness that affects children, especially the small children. Babies aren't vaccinated, fully vaccinated until they're a year old. So if you're around children under a year of age, you're protecting them from pertussis because you can get it. It seems like a really bad cold, and you can probably get over it as an adult because you've probably had the protection through your lifetime. But babies aren't protected. But if you have it, you can give it to babies. So this protects other children. It'll also protect you as a boosted immunity if you are exposed to pertussis. You cannot be yes. In addition to that, you get the tetanus. So if you get cut outside doing yard work or anything, you're protected against tetanus, which is still in the same. Will you see all the way up?
Yeah. Don't make me face, I'll be crying.
No. I give shots to babies, so maybe it won't hurt so bad.
Cry?
Well, yes.
No, I'm okay.
Okay, are you ready? Take a deep breath and blow out.
Oh, it don't hurt. It's okay. Very good.
Well, thank you.
You too, certain days you get poked so much with needles.
This is true. All right.
Thank you very
Now,
much.
what I will tell you is tomorrow, the muscle of your arm will be sore. It's not going to prohibit you from doing anything. You just have to remember if you go to reach up for something, you're going to feel an ache, it's because of the tension.
Okay.
It does hurt for about 24, 48 hours. The other option is you can go home, tell your husband he's got to do all the housework, cook you dinner, and bring you flowers. That's the only way your arm will feel better.
That works.
Okay.
Now see, this is on film and he'll know.
My name is Joe Sykes and I'm with AirEvac Life Team, and what we do is we supply a helicopter service if you need air medical service. Nowadays helicopter service is really extremely important and expensive, and what we do is we kind of take that bill away. If you're a member, for $65 a year per household, we will cover you and you will not have a bill. Well, whatever insurance pays is what they charge. That's all we had to say.
I can get you signed up if you would like.
He's got some too. Women who smoke are at increased risk for reproductive health problems. True or false? And which of the following risk factors for heart disease can you reduce through lifestyle change? Smoking, high blood pressure, obesity.
All right, we thank you all for coming. Hope you're enjoying the day, having a good time. It's about time we got some decent weather. So we were kind of sweating it that we would have lousy weather again today, but it's a great day out there. So we're glad you were able to come out and join us for a few hours on this great Saturday. The presentation you're about to hear is Dr. Matthew Bosner. He is Director of our Cardiology Services here at St. Genevieve County Memorial. And he's going to talk a little bit about the myths of heart disease and what you can do to help your heart out right now. So, Dr. Boss?
Thank you very much, and I appreciate you all coming on this beautiful day. And as Stephanie said, we are delighted that you're here visiting us, and we greatly appreciate the time you spend with us here. It's a delight to have the opportunity to meet you all. Again, this is the third time I've had the opportunity to visit with you and talk with you about new issues related to cardiovascular disease and how what we could do here at St. Genevieve County Memorial Hospital here in your community to work with you on a regular basis to keep you healthy on a day-to-day basis in preventing heart attacks and strokes. And what I'm going to do today is spend just a few minutes discussing new issues related to information on prevention of heart disease, and just spend about 10 minutes on that. Then I'm going to go through common myths and misperceptions on cardiovascular disease, and I'm going to be addressing the wonderful questions that you've all submitted. And everyone that submitted a question, and it seems like almost everyone has, is going to get a book, and everyone will get a book by the time we're done with this. And I'm going to also be discussing, I have a lot of handouts that I would like you all to partake of at the end of the at the end of our meeting today. I hope this will be a very interactive discussion because the point of this is for you to find out what you would like to know about questions that you have, and for us to provide information that we have here and services that we can provide for you to help you feel comfortable in your care, and information that you might know about services that we could provide for you and your family and your loved ones here at the different facilities that we have here at St. Genevieve County Memorial Hospital. The theme of my talk today is the fact that I love art. And all of you who know me or know about me know that I love art. And I'm going to talk today about the relationship of the art and science of individualized patient care. And that's what we emphasize here at St. Genevieve County Memorial Hospital, is that every patient and every family that comes to see us is an individual. And there's no such thing as cookbook medicine here at the hospital. And every patient and every family is an individual. And we don't just treat every patient with hypertension the same. We don't just treat every patient who's had a heart attack the same way. We have to compose the patient's care to their individual needs. Just like an artist has to compose a painting or a sculpture in an individual manner. A concept that's very important to remember is the fact that the blood vessel system, or what we call the cardiovascular tree in the body, is connected. The blood vessels in the heart are not different than the blood vessels in the kidneys, in the legs, in the arms, or in the brain. You may see one of us and you say, oh, I have problems when I walk, I get pain in my leg. And your provider may say, oh, we have to worry about problems with circulation in your leg. Let's do some tests. And you come back and say, yes, Mrs. Smith, you have problems with circulation in your leg. And you have testing and medication started. But also, Mrs. Smith, now that we know we have circulation problems in your leg, we also have to be concerned about circulation problems in the other blood vessels of your body, because the circulation is common. So we'll have to do an evaluation of your heart, and sometimes circulation evaluation of the brain, because it's a connected system. So the doctor may commonly have the patient see me for a cardiovascular evaluation. They may order a stress test to make sure the circulation of the heart is fine. It's very common if the patient is going to have surgery on the leg, what we call bypass surgery, or if the patient has what we call an aneurysm, which is the dilatation or an irregularity of the main blood vessel in the abdomen, they will have a stress test or an evaluation of the heart to make sure the heart is strong and can tolerate the stress of the surgery in the abdomen. So it's very important that we have a full evaluation of the cardiovascular system. So these blood vessels are not isolated throughout the body. There's no difference. This blood vessel can be in the brain, it can be in the neck, it can be in the heart, it can be in the leg. And here we see an abnormal blood vessel with thickening, irregularity, cholesterol deposits and thinning, and here we have a nice wide blood vessel with circulation, and here it's thickened, irregular, and here's a blood clot which clotted off the artery, and after this clot, there's no blood flow. And if this is in the heart, this would be a heart attack. If this was in the brain, it would be a stroke because there would be no blood flow after this area. If this was in the leg, this person may have pain or decreased circulation in the leg. So depending where in the body the blood vessel is blocked, that's where the symptoms of the problems would occur. So that's why we have to do what we call a global evaluation of the circulation in the body. So in the heart, we can have damage or death of heart tissue called a heart attack. The brain on the right, top right, would be a stroke. This is a aorta, which is the main blood vessel of the body. This was a sample taken from an autopsy of a 17-year-old who was in a motor vehicle accident and died. You can see that he already has irregularity of the blood vessels. This is a 17-year-old who already has evidence of irregularity, atherosclerosis, and a 17-year-old already has damage to the blood vessel. And on the bottom right is what we call an aortic dissection, which is a rupture of the walls of the main blood vessel of the body called the aorta. One common feature that we always talk about are risk factors, what we call cardiovascular risk factors, which is what can we do to evaluate and talk with the patient on an individual basis. What can we do when we talk to you about working with you and dissecting from your information your personal risk? How common would it be in your situation that you would have a chance of having a heart attack or stroke, and then what can we do about it? Now, one critical feature in this is that when we talk about cardiovascular risk factors, we're comparing your individual situation compared to other common situations we see in populations. Now, I tell patients this every day in my office. I must use this analogy 10 or 15 times a day. When we talk about risk factors are population-based. It's based on thousands and thousands of patients. You are one individual. So when I say that patients who have a total cholesterol level of 200 have a higher risk of a heart attack than individuals with a cholesterol level of 100, that means that there's a higher chance. It's like going to Las Vegas and playing a game at a Las Vegas gambling game. There's a higher chance. That doesn't mean you will have a heart attack or you won't. That means the odds are much higher that you will have a heart attack or stroke if your cholesterol level is higher. It's a statistical probability. It doesn't necessarily mean cause and effect. It doesn't mean it'll happen in a certain time frame. It means that there's a statistical relationship. Now, the common factors that we categorize into modifiable risk factors, which are common factors that we can intervene with, that when we know that we see in your particular situation that we change, that will improve your chances against having a heart attack, stroke, or problems with circulation in your arms or your legs. Or the key ones are smoking, dyslipidemia or abnormal fats in your body, diabetes, and high blood pressure. And what we call the non-modifiable risk factors are your age, particularly individuals over the age of 60. You can't turn back the aging clock, unfortunately, right now. Men and postmenopausal women, okay, women who go into either natural, chemical, or surgical menopause are, and I'm going to talk about this in great detail when I talk about one of the very common myths and misconceptions about heart disease. That's one of the main myths that I'll discuss, is that once women go through menopause, either chemical, surgical, or natural menopause, their risk on an age-based basis for heart disease actually becomes greater compared to a man at the same age. And I'll discuss why that is, and I discuss that myth in particular. Okay, family history of premature heart disease. That's very important, okay? When we talk about family history is relevant if the person who you're discussing was an individual under the age of 55 and they were a non-smoker. That's very, very important. The second question, when providers such as Jody or I ask the question, the second question we always say when someone comes in and said, oh, I have a terrible family history of heart disease. The second question we always asked was were they smokers? Because the generation ahead of us were commonly smokers. They commonly smoked 2 packs of Lucky Strikes a day, 3 packs of Lucky Strikes a day. Smoking is such a potent risk factor that if they were smokers, you just throw that out as a risk factor. Because the family, smoking is such a potent risk factor, you just throw out the family history. Because smoking is such a powerful risk factor, that is the risk factor. It wasn't the family history, it's the smoking. The smoking is the powerful risk factor. The other thing that's very important to separate out with family history is social history. Now, sometimes that's very hard to do because with family history, you have social history. You have the concept of eating. Families have the same eating habits, the same social habits, commonly the same exercise habits, the same religious habits, the same exercise habits. So when you talk about family history, you're not just talking genetic history, which is what's usually implied with this. You're also adding social history. So when we talk about this, it's important for the provider to separate out those issues. It's not just genetic history, it's social history, smoking history, and the whole package. So it's important to separate out those questions. Now, that's one set of issues on risk factors. The most important question that a provider can discuss with you and you can provide to your medical provider is, have you had a previous cardiovascular event? Once you've had a previous cardiovascular event, anywhere in your cardiovascular tree, a heart attack, a stroke, bypass surgery, a stent, you're already talking about secondary prevention. It doesn't matter where in your cardiovascular tree it is. So you're already at high risk for another event. The most important predictor of a secondary cardiovascular event is the fact that you already had one. That's common knowledge, that makes sense, and that's true. The most important predictor of a second heart attack is the fact that you already had one. So you're already at high risk. And that's a key feature. So right there, you're at high risk. So that puts you at high risk. The second group of patients that are at very high risk that I'll discuss in detail are patients with diabetes. Patients with adult onset diabetes are at the equivalent risk for a heart attack or stroke than patients who have already had a previous cardiovascular event. And I'll discuss why that is. So patients who have had a previous heart attack or stroke, or patients who have diabetes, are at very high risk for a subsequent cardiac event. So when we see a patient, there's a process we go through. We have to evaluate the patient. We have to set goals based on what their risk is. Are they at low risk, medium risk, or high risk? And then we treat. And you have to go through this process. You have to go through this algorithm. You have to evaluate a patient. You have to set their goals based on what their risk is. Are they at high risk, medium risk or low risk, and then you have to treat based on what the risk is. This is one of the handouts that I have for you. That's at the back of the room, and one feature that has recently been published that changes how we've been treating cardiovascular disease for the last 30 years. This change in the last 2 months is this concept of global cardiac risk. In the past, you've heard us all say, treat the number, treat the number, treat the number. And when you think about it, it makes no sense. And what a lot of us have been saying for years is, nobody ever dies of a number. Do you die of a blood pressure of 130? Do you die of a blood sugar of 180? Do you die of weighing 190 pounds? No, you die of a heart attack or stroke. 90% of diabetics die of a heart attack, stroke, or a complication of peripheral vascular disease. They don't die of a blood sugar of 300. They die of a cardiovascular event. Now that's a fundamental concept, but it has only been adopted by the medical and national agencies who made guidelines in the last 10 weeks. Now that may seem very simple to you, but this has been a huge change in how medical societies and guidelines and recommendations are made. In September of 2013, the National Institutes of Health, which is funded by your tax dollars and mine, said, we are not in the business of providing guidelines anymore. We're leaving it up to the agencies. They turned cardiovascular guidelines back to the American Heart Association and the American College of Cardiology. They say, this is what you all do, you make the guidelines. So, with respect to blood pressure and cholesterol guidelines, the two major societies sat down and said, okay, this is what we're going to do. And I have this for you in the back. And there's three groups of patients who are going to be treated, categories of patients, and this is how we categorize patients for treatment for their blood pressure. If you're over the age of 60 and you have no other risk factors, your cholesterol is normal, you don't have diabetes, you don't have chronic kidney disease, and you haven't had a previous cardiovascular event, if your blood pressure is over 150 over 90, that's when you start to be treated for your blood pressure. Now that was raised from a blood pressure of 140 over 90. But when you think about it, there are very few patients who don't have another cardiovascular issue or high cholesterol or haven't had an event, at least in our population here. Most patients are going to fall under the previous cutoff point of 140 over 90, and that's where we treat, which is 140 over 90. So we're going to stick with the old guidelines of 140 over 90, and that's the rest of the patients, which is 140 over 90, and that's our cutoff point here at St. Genevieve County Memorial Hospital. That's our standard of care, 140 over 90. So we start treating patients at 140 over 90, and we treat patients usually with a single drug. Unless their blood pressure, they come in, and if it's very high, we'll start them on a combination therapy. And we see them back in 2 weeks, because it takes 2 weeks for medications to stabilize in your system. And then we repeat their blood test. Now, treating your cholesterol level, we're treating to improve life expectancy and to keep you alive. We're not treating your number. In the previous guidelines, we said, get your cholesterol level down, your LDL or bad cholesterol level down below 100. We weren't saying, keep you alive. Now we're basing our treatment on studies which say these four groups of patients, if we treat patients in this manner, these patients will stay alive longer. We treat patients if they've had any patient who's had a previous heart attack or stroke, patients whose LDL cholesterol, which is the bad cholesterol, is very high, over 190, patients with diabetes and their LDL or bad cholesterol is over 190, or patients who have an LDL cholesterol of 90 and their risk for a heart attack or stroke is over 7.5% over the next 10 years. Now the question is, how do you calculate that? And the way you calculate it is you go to a website called a risk calculator. Click that first Google, then you hit download CV calculator. So it's 2 clicks on your computer, and then you do open. And then this is what you get, okay? And all you do is you type in what's relevant for you. If you do this, I promise you this works. And then what you do is if you go into this link and then you click back and forth, you'll see the dramatic effect of adding diabetes and not adding diabetes. It doubles your risk. You add smoking and take smoking away. It's an incredible change. So now the issue is, you know, this is where we are. And this is kind of, Jody's here. But, you know, the main issue is now we got to do something about it. We talk on the bottom page of those guidelines. We're getting into the myths here now. When we get into the guidelines talk about obesity. And the reason obesity is critical is the relationship, I think the next page, is the relationship between obesity. There's a linear relationship between obesity and diabetes. And that's the critical issue, is that there's a national epidemic of diabetes because there's a national epidemic of obesity. And when you look at, I mean, the overlap is absolutely incredible. And, you know, there's no way really around this. And there was even a movie called Super Size It or something like this. And it comes back to the whole concept of diet and portion size. It's very important that one of the measurements that we always do, thank you, when you go into your provider's office is we do your weight, we track it. We have an excellent program that we started here at the hospital called Transformations. It's a superb multidisciplinary clinic that Jody Uding, one of our nurse practitioners, has spearheaded with other practitioners and physicians. And we have excellent resources. They have great choices, counseling. There's a strong exercise component. There's physicians involved for medical supervision. One example here, if you want to stand up and show that, we have a booth here to go by. Now, wait, have them guess what that is, because that's going to be the first book.
Pass it around. Pass it
Okay. Well, people, no, that's fact. So their job is to guess how much that is. Somebody who doesn't know. Somebody who doesn't know, how much fat is that?
That's about 4 Twinkies and a dilly.
Somebody who doesn't know the answer, how much fat do you think that is? Give them 3 choices.
How many pounds?
Give them 3 choices.
Okay, we'll start. First choice is 4 pounds, 7 pounds, 5 pounds, or 10 pounds.
Okay, good. All
5
right,
pounds.
they get the first book.
With
Okay.
transformations, our folks are losing 14 pounds a month.
Okay, that's awesome. Okay, whoever got that gets the first book. All right. So, one of the handouts, I have this written out for you. We're kind of running low on time. And I gave this handout also last year. A quick calculation, just kind of quickly for weight, ideal body weight, and they go over this with you in excruciating detail, is for a female, it's about 100 to 105 pounds for the first 5 feet, 5 to 6 pounds per inch okay, after that. You need to consume 10 to 13 calories to maintain your current body weight, okay? To lose a pound to 2 pounds per week, you have to decrease your calorie consumption by 500 calories a day, okay? Now, as I talked about how we work with patients, I love art, okay? Now the question is, medicine would be easy if the easel had 3 or 4 separate problems. You were able to say, okay, Mrs. Smith, this is your problem. It's A, B, C, or D, and this is what we have to do, right? Rita knows that, Jerry knows that, I know that. But that's not the problem. This is the real patient, and this is a real artist palette. Okay, this is an artist friend of mine, and this is how he puts together a painting. He goes through it, he conceptualizes it, and over time, he goes from a blank canvas to a complete work of art. Now, this took several hours to do, and let me go through that. And the reason it's important is when a patient comes into us, a patient has a history that we don't know. We have to think about it, put it together, and piece together the patient's history. Now, this may be a patient in family medicine who's 8 years old. And this is a patient who's 10 years old. This is a patient who's 18 years old. And this is a beautiful picture when they're 30 years old. But it's different when you're 40 years old. And here's a different, beautiful picture when they're 60 years old. And here's a beautiful painting when they're 70 years old. And here's a beautiful painting, you know, when they're 80 years old. And they're all great paintings. But the point is, it's not the same. And they're all beautiful paintings. And it changes. And that's why it's important to come in for your regular visits. Things change. Your conditions change. You change. You go to other physicians. They change your medications. They change the colors. The colors fade in your house. We need to evaluate you. You need your basic artist, who's your primary care physician, to work with you and help modify things. You may want to change the frame, okay? It may not be right, okay? And that's what the primary care doctor does. Can you put that up here? So this may be, you know, this may be the painting, you know, now, you know, and here's a beautiful painting, you know, when you're 80. It'll support it. But you see, it was 10 different paintings through the ages. And they're all good paintings. They're all beautiful paintings. And that's why you need to see your doctor on a regular basis, your provider, because things change. And open communication is important. And you need to talk with each other and communicate. Because they need to know what's going on with you. You need to let them know as things change, as the colors change, as the lighting changes, the lighting in your life changes, conditions change, right? You move to a different house, it's a totally different painting. You turn the lights up, you turn the lights down, the painting's different. It's a totally different painting if you move into another room. And that's what art is. It's totally different when you move it around. Let's talk about some myths. I hear this all the time. I know when I'm having a heart attack, so I'm going to have chest pain. One of the most common things we hear from women. 50% of women who present in the emergency department with a heart attack don't have chest pain, especially over the age of 60. The most common presentation of a woman over the age of 65 with a heart attack is what? Shortness of breath. Absolutely. She gets a buck. Okay? Absolutely. And the reason is, it's heart failure. And the reason is women, especially when they're older, present with multi-vessel disease. They present with disease in multiple small vessels. They have smaller blood vessels. They have smaller hearts, and it's usually involving multiple small vessels. So they present with usually more diffuse disease. They usually present older in life, and they usually have, they more commonly have diabetes and high blood pressure. And they usually present later in their heart attack. Because women are great at telling their husbands, to give to others to get to the hospital, and they present later. Women are great providers for everybody else except themselves. Women present twice as long to the hospital after a heart attack. The men usually present within 20 to 60 minutes to the heart attack. Women present 1 to 2 hours after a heart attack. The same with the stroke. So if you have symptoms, you take an aspirin, okay, an uncoated aspirin. Okay, it's very important. I bought this at Country Mart 2 weeks ago. Okay, I think this was 50 cents. Okay, you need to buy yourself, even if you take a regular aspirin every day, you need to buy your, and usually you take coated aspirin to protect your stomach. You should all buy yourself a bottle of uncoated aspirin, because if you're having a heart attack, okay, you want to chew an uncoated aspirin because you want to get into your system faster.
Can't you use baby aspirins?
Yeah, that's what these are, but the uncoated,
Right.
okay? The other thing you can do is take an old-fashioned Alka-Seltzer. Because the old-fashioned Alka-Seltzer, the one with the dark blue label, the plop, plop, fizz, fizz, oh, what a relief it is aspirin. The new one is acetaminophen. So the old aspirin, if you look at the ingredients on the original Alka-Seltzer, it says aspirin. And that would work just fine also. Very good. Okay, myth number 2. If you take a cholesterol-lowering drug, you can eat anything you want. Absolutely not true. And the reason is because because cholesterol comes from 2 sources. It comes from the diet and the intestinal tract as well as the liver. The medications we use affect the cholesterol metabolism from the liver, but it has nothing to do with the cholesterol that's absorbed from the intestine. I know a little bit about this because in my previous life, this is what I did. I worked, I'm going to skip all this. This is what I did for about 15 years of my life when I was at Washington University. We developed a test to measure cholesterol absorption from the intestine. It was the first time it was ever done without radioactivity. Did this and published this in 1990. Well, we published our first paper in 1993. We actually got a patent approved in 1992 to measure cholesterol absorption in patients. We actually were surprised that it was approved. We actually never thought it was going to be approved. It was approved on the second pass, which is relatively uncommon for a patent. Usually it takes much longer. Then we did multiple studies. This is our first patient study. Patients absorb, on the average, 53% of your cholesterol. But there are some patients that absorb a lot. Some patients absorb less. Some patients are high absorbers. Some patients are low absorbers. Why is that important? This is why it's important. When you look at patients that are high absorbers, patients that absorb 60, 70, 80%, those patients do really well if they use products in their diet that block cholesterol absorption. What products block cholesterol absorption? Well, things that block cholesterol absorption are fiber in your diet. Oatmeal, and margarines that contain products called phytosterols and stanols. Benecol, margarine, has dissolved plant sterols in it. And this is an interesting one I just got at Country Mart the other day. This is actually butter. It's 50% butter with dissolved olive oil in it. And it has 100 milligrams, which is 0.1 gram of plant stanols in it. Okay, so this actually is butter that you can use the fried things, with plant stanols in it. The recommended dose is 2 grams a day. This is actually 1/4 of the daily, one portion is 1/4 of the recommended daily dose of stanols. This is 1/10 of the dose. And this is butter. This is 50% butter. This is a pure margarine. So these are available. And actually, these products were actually tested with our method. They actually used our methodology to test it. This is actually how they came to market. They actually got FDA approval for this few little words. Helps block cholesterol in your blood. They got that label because of our testing that they used, which was kind of fun. Myth 3, heart disease runs in my family, so there's nothing I can do to prevent it. Well, we already discussed that, okay? The family history is generally used as a crutch. And I think I pretty much debunked that myth already. Much of the family history is the social history. We can break that up because of the smoking, the social history, the eating history, and you can discuss that because of social, exercise, weight, et cetera, et cetera. We already discussed that in detail earlier. Diabetes won't cause heart disease if you take your diabetic medication. Well, tight control of diabetes is excellent for controlling your retinopathy and nephropathy, what we call small vessel disease. But tight control of diabetics has never been shown to decrease cardiovascular outcomes. And as I mentioned, 90% of patients with diabetes die of a heart attack or stroke. Patients with diabetes need to be on cholesterol medication, need to take an aspirin every day, and need to be seen by a cardiologist every 1 to 2 years, as I think the next slide shows. These are the recommendations for a follow-up. Okay, remember, 80 to 90% of people with diabetes have coronary artery disease, stroke, peripheral vascular disease, or heart failure. Cardiovascular disease results in 75% of hospitalizations for diabetic complications. There's increased mortality, which is death. Morbidity means complications after a heart attack and stroke, and it's much more profound in women. This is the study that I alluded to earlier that shows in patients with diabetes, which is shown on the right, without a previous heart problem, have the same complication rate as patients who have had a previous heart attack. So if you have diabetes and have not had a previous cardiovascular problem, you're at the same cardiovascular risk as a patient without diabetes who already had a previous heart attack. So your cardiovascular system is already in trouble because you have diabetes, just like you've had a previous heart attack. Those numbers are very close, 20.2 and 18.8. That was done by Steve Hafner at San Antonio and published about almost 20 years ago now. Another very important point of diabetes research is by the time we make the diagnosis of diabetes, patients have had abnormal glucose metabolism for about 10 years. By the time we actually diagnose diabetes, which is made by a fasting blood sugar of greater than 126 on 2 occasions, or a postprandial, which means after eating blood sugar of 200, or insulin glucose tolerance test, which is abnormal. Their actual glucose or blood sugar metabolism has been abnormal for 10 years. That means the insulin regulation in your body has been abnormal for 10 years. That means we're measuring the wrong thing. That's what it means. So we have to come up with a better test. And of course, there's a lot of research which is going on about that. So the recommendations of the American Diabetes Association, which I've been a member of for the last 15 years as a cardiologist because I feel so passionate about this, Patients with signs and symptoms of coronary disease need a full cardiac evaluation. Patients with peripheral or vascular disease. Patients over the age of 35 with diabetes who have a sedentary lifestyle, who are going to begin an exercise program, need to see a cardiologist for a stress test before they begin exercising because they're at such high risk. Patients with 2 or more of the following risk factors, okay, in addition to diabetes, are supposed to be referred to a cardiologist for evaluation. They have elevated total cholesterol, LDL or bad cholesterol, which is high, or low HDL, good cholesterol. They have high blood pressure, cigarette smoking, family history, and positive protein in the urine. Next myth. It's okay to have high blood pressure when you're older. This was the old myth. You take your age, what was that? It was 100, what was it? 100 plus your age, and that was an okay blood pressure. And the old concept was you needed a high blood pressure to push that blood up to your brain. Well, that was really the way it used to be thought. Well, when you take, the heart has to work so hard to push the blood out, that's what damages the blood vessels. And now we know that that's the problem, but that really was the concept of treatment. And that's why people had strokes and died. And it was very sad because simply treating patients with blood pressure, medication, will totally decrease strokes and in individuals up to, and these studies have been done up to age 95 or 100. And this study shows that in patients up to age 95, by decreasing systolic blood pressure by 5 millimeters, just by 5 on the top number, you decrease stroke by 25%. If you decrease the top, this is combining 43 studies. You drop the top number by just 10 on the average of all these studies, you drop stroke by a huge amount. You drop by 20 of the top number, you drop stroke by about a third. You drop by 40, you drop by about 50%. So if your blood pressure is 160, 170, you drop it down to 140, you could drop your stroke rate by about a third to 40%. I mean, it's incredible. And it's not that hard to do. These are the blood pressure recommendations, which I have on the handout. Next myth, I smoked for years. You can't reduce your risk by smoking. Okay, this has been shown in multiple studies. When you stop smoking from a cigarette, from a cardiovascular perspective, within 3 to 6 months, okay, after quitting, your risk of a heart attack or stroke drops by 50%. Okay, in 1 year, it approaches that of a non-smoker. Okay, in most patients, within 1 to 2 years, it's absolutely back to that of a non-smoker. That's the risk of a heart attack or stroke. Now, the risk of cancer is the cumulative amount that you've smoked. And that's why when we talk about smoking for cancer, we talk about pack years, how much you've totally smoked. When you look at cities that initially had smoking bans, such as Des Moines, Iowa, Detroit, they had the first smoking bans. They had the most rapid decrease in heart attacks. Des Moines, Iowa was the first city that had public smoking bans. They had the greatest decrease in heart attack rates. You couldn't smoke in bars and bowling alleys. They had the fastest rate of heart attacks. That's what people did on Friday nights. They went out bowling, they went out to eat. And what do? You smoke 2 or 3 packs of cigarettes. When you stopped smoking in bars and bowling alleys, the heart attack rate went down tremendously. And that study was published, you know, about 8 or 10 years ago. It's incredible. I love that slide. Okay, this is probably one of the most important slides, I think, of the whole talk, which is the concept that in women, and this is talking about natural menopause or the effective aging. Okay, definitely by the age of 65. And this is excluded. This is done with the Framingham Natural History Model. Okay, cardiovascular disease is the leading cause of death in women over the age of 65. 70% of men and women have cardiovascular disease, which is coronary disease, heart failure, stroke, and hypertension. The risk continues to rise, and by age 80, 83% of women and men, okay, have some type of cardiovascular disease, okay, and death for cardiovascular disease is the #1 cause of death of women over the age of 65. It's not breast cancer, okay, it's not any kind of cancer combined. It's cardiovascular disease. Okay, exercise. Okay, after, if you're in the hospital for a cardiovascular event, once you release, the first thing we like you to do is get into a cardiac rehab program. We want you to start exercising in a controlled situation, and then we can let you start doing exercise on your own. But we like you to start in a controlled situation, and the recommendations are 150 minutes a week of moderate exercise, or 75 minutes a week of vigorous exercise. And we, like I said, after a hospitalization, we like, if possible, to do it under a controlled situation. This is another slide that I absolutely, you can see how much I've used it. It's totally blurred out. You can't think about it, you gotta do it. And the other sideline of this that I always talk about is people talk about walking at work. That doesn't count as exercise. You don't count those minutes. It has to be dedicated exercise, at least to the point where it's difficult to start talking. That's the minimum time factor. Your warm-up time and warm-down time doesn't count. Okay, a small heart attack or a mini stroke can't be blown off. If people tell you you had a small heart attack or a mini stroke, what we call a TIA, don't blow it off. Okay, don't let your provider blow it off. Don't let the ER blow it off. It could be a warning sign of what the big one. Okay, make sure you go back to your provider for follow-up. If you're in the emergency room, make sure you see your provider in the next few days. You need full testing. That's very, very important. Okay, because as I mentioned, the most common risk factor for a cardiac event is the fact that you already had one. I know I love art, but I also love my little doggy too. So I had to throw a slide like that in. Oh, I'm sorry, I didn't say what that was because I got lost on my little doggy. Okay, and okay, the last myth is a procedure. Angioplasty, stenting, or bypass surgery will fix my heart. This is the surgical model. Now, surgeons these days aren't like they were about 10 years ago. A surgeon would come out and say, oh, you know, Mrs. Jones, I want to give you great news. You know, we did bypass surgery on your husband and he's fine now. Okay, they're not like that anymore. They used to say that. We fixed your husband, everything's fine. They're not like that anymore. They're much more what we call medically oriented. You know, they are good about getting you back on your cholesterol medicine, your blood pressure medicine. They harp on not smoking. One reason is they have to, because they have a little checklist like we do. They get marked off if they don't talk to you about not smoking and all that. So it's critical to go back to your provider, to stay on your medications. And even if you have a procedure, the disease is still there. They just gave you another type of therapy, which is the surgical intervention. So this is the summary statement. It's important to work on your dietary weight management program. It's really important to talk to your provider to get into a weight management formal program. Our program here is excellent. They will work with you on getting the right program for you, be it a medication program, an exercise program, whatever works best for you. Exercise 150 minutes of moderate or 75 minutes of intense exercise, getting your cholesterol to go, diabetic control, blood pressure, taking aspirin every day. There's some questions about aspirin. Okay, in women, okay, aspirin is recommended every day if you've already had a cardiac event, like a heart attack, a stroke, or a procedure, like bypass or peripheral vascular disease. if you have not had a previous event, if you've not had a previous heart attack or stroke, there's no benefit of taking an aspirin to prevent your first event. In men, it's recommended to start an aspirin at baby aspirin at age 40. In women, it's recommended to start after you've had a cardiovascular event. That's the difference, okay? Let me write that down. Okay, in men, and that several of you asked that question. Okay, in men, age 40, for all women, after cardiac event. Okay, that's the recommendation, 81 milligram of aspirin. And the reason is that there has been shown some studies, some increased bleeding, some increased intracerebral bleeding, especially women that still have their female organs. There's some gynecological bleeding noted, not fatal, but so the recommendations are men over the age of 40, 81 milligram aspirin, women after your first cardiac event. Vitamins. There was another one I left off, another common question. There's no benefit, okay, of taking any exogenous additional vitamins, okay, for cardiac protection besides the vitamins that are already in a good nutritious diet. So extra outside vitamins, okay, are not necessarily additionally protective. Okay? So let's leave it at that. I will be around for extra questions, and we have, okay, we'll take your question, and then we have books for everybody.
If you've been taking the 82 milligram, 81 milligram aspirin every day for longer than a year, can you just stop it?
Yeah,
Okay.
okay, and I'll be around for other questions.
Is calcium, taking calcium supplements bad for your arteries?
No, it won't add calcium or thicken or irregular heart, but that's good for your, it's important for your bones. Do you have a question?
What about exposure to secondhand smoke for like 30 years?
Yeah, secondhand smoke is particularly bad for your lungs, and it's not very good. It doesn't promote atherosclerosis, but it's particularly bad for chronic lung disease. It gives you the 50% of your risk for chronic pulmonary disease. All right, well, I really appreciate you coming. I hope you learned a lot today and from the rest of the forum, and I'm available for any of your other questions.
Channels 7 and 98 TV and web broadcasting are made possible through contributions and donations from viewers like you. Thank you for your support.